Hello, I'm James Dowdell. Welcome to the right tool for the right job, choosing and using topical hemostatic agents in hospital outpatient departments and ambulatory surgery centers. This CME initiative is supported by an educational grant from Pfizer, Inc. This is the first of 3 CMEO snacks, and we'll cover choices in topical hemostatic agents. Again, I'm James Dowdell. I'm an assistant attending orthopedic surgeon at the Hospital for Special Surgery, where I work in spine surgery. I've been there for several years now, and I'm very pleased to be joined today by my colleague, Michael Capito. He's a perioperative nurse with the Hospital for Special Surgery in New York City. Welcome, Michael.
Hi, thanks. Thanks, Dr. Dowdell. Happy to be part of this important program. As you mentioned, I'm also a perioperative nurse. I work also at the Hospital for Special Surgery. I've been here for several years. I do work in all our various orthopedic procedures that we do, but mostly also with spine.
So here's our learning objective for today's program. If they're participating in this activity, learners should be better able to assess the role of topical hemostatic agents for specific types of bleeding in hospital outpatient and ambulatory surgical procedures. As you know, hemostasis is critical to success of surgical interventions. It mitigates blood loss and prevents the need for transfusions. And as we can see by this graph here, there's a trend towards more outpatient surgery. So every year, we do less and less inpatient surgery and more outpatient surgery, whether that's outpatient in the hospital or ambulatory surgery center. And the important thing is for making these surgeries successful. So we think about hemostatic agents, they've evolved to be used in these outpatient settings to decrease the use of hematoma or decrease drain use. And that enables patients to potentially go home. Now, specifically in orthopedics, the trend is towards more outpatient surgery. You see here in my procedures, spine surgery, lumbar microdiscectomy, if we talked 20 years ago, we never did those procedures outpatient. But now I would say half and half are outpatient versus ambulatory surgery centers. We need to make those surgeries safer. What's the most significant worry that I have is the potential for a readmission. Proper use of a hemostatic agent can help prevent some of these readmissions. What's the one that I worry about the most? A hematoma. I worry about infections. If we have less dead space, we have less seromas, less hematomas, potentially get less infections and less chance for readmission right after surgery. Now, there's various methods that we have to achieve hemostasis. Our focus today is going to be on the topical hemostatic agents, but I'd be remiss not to talk about the other agents as well. So the tried and true method, mechanical pressure, direct pressure, closing a wound, staples, it's always going to have a place in surgery. Now, ultimately, we want to talk about other agents as well. Thermal or energy-based, electrocautery, bipolar cautery. I don't typically use ultrasonic devices or lasers, but there are potentials in other fields. I use electrocautery mostly for my dissection. I use it for prevent muscular bleeding before it starts. And bipolars I use for epidural veins around the nerves. Now, I worry, though, if I use electrocautery too close to a nerve, it could potentially cause a nerve root injury. So I like to have other adjuncts, and that's where the topical hemostatics come in. Pharmacologic, I think that has a role as well. Lysine analogs, which is tranexamic acid, they help stabilize the fibrin clot. I give that to my patients routinely, whether it's systemically or topically. Epinephrine, great for before you do a surgery. It can constrict the blood vessels around the skin where you make the incision. Vitamin K and protamine, they're great for reversal agents for people on Coumadin and heparin. So everything has a role, but we're going to focus on the topical hemostatic agents. So they're broken up into different categories. You have the mechanical, which is cellulose-based products, gelatin-based products. Active, which is thrombin. Typically, I use a mixture of mechanical and active. We have flowables, which are just the mechanical gelatin-based products that are broken up into a more liquid consistency so they get to hard to reach places. And then you have the fibrin sealants. So let's go to the main categories and examples of each. So we have the mechanical. What do I typically use? I typically use oxidized cellulose, which is Surgicel. I don't have the polysaccharide spheres available to me, but Aristra is an example of that. Gel foam, which is a gelatin. I typically mix that with thrombin. So the mechanical basically works by helping create a platelet aggregation. It also helps stabilize clots that already exist and a tamponade effect to stop bleeding. Now, active, that helps stimulate the clotting cascade. So thrombin, you're giving thrombin to a patient so they can stimulate their own clotting cascade. A mixture of the both is probably the most effective. Flowables help getting to the hard to reach places. The flowables that I know of in my hospital are FlowSeal and Surgiflow. But Gel Flow NT is a new flowable that actually is good for cancellous bleeding. I just haven't had a chance to use it yet. So this is gelatin granules, and it's mixed with or without thrombin. I'll tell you, I typically use it with thrombin. Then you have fibrin sealants. Topical, Topical are the ones that I typically know of. This is a combination of thrombin, fibrinogen, sometimes other components, but essentially you're mixing thrombin and fibrinogen and helping create a clot in the wound itself. Now, Michael, you work on a variety of procedures. Are there particular hemostatic agents you see more than others?
Oh, absolutely. So whenever I start a spine case, especially with a surgeon I am not familiar with, I kind of always go to my go-tos. You generally see them using Surgiflow as their flowable, and they'll also take gel foam mixed with thrombin. But we do have several surgeons here, and some of them have their own specifics. So I've seen we've pulled out things like Surgicel from the Nunit and the Fibrillar, to even things like Flow Seal, like Dr. Dell mentioned, and also I've seen the use of Hemosorb, which I think acts like a bit like a pencil. But yeah, ultimately the best thing as part of the surgical team you want to do is communicate with the surgeon to what they would prefer to use for their hemostasis.
No, I think it's a great point. You can see, right, the choices can be overwhelming for the amount of products there are. So you want to know what the surgeon wants to use and what they're comfortable with, because that enables successful surgery. So I think that's a great point. Communication between the teams is fantastic. So hemostatic agents are used in several specialties. My own experience is obviously in spine, so that's why it's highlighted in red here, but you can see it's used in general surgery, cardiac surgery, gynecologic, ENT, urologic surgery. It's important for everything, right? So bleeding is universal in surgery, and what we want to do is help prevent that. So there are many types of bleeding, and you can manage them with various topical hemostatic agents. So you have diffuse raw bleeding from multiple bleeding points. I typically think of that as muscular bleeding. What's good for that? My go-tos for that, or if I'm doing a dissection, an open dissection, I want to make sure that I have a flowable and Surgicel on that muscle while I'm going to another area of dissection. You can think about Aristra is a good example of this. You could spray it over the muscular bleeding. Bleeding close to bone. Okay, it depends on if we're talking about cancellous bone or cortical bone. Cortical bone, where you have the feeding vessels into the muscle. Typically, I use electrocautery. I'll use a flowable and Surgicel sitting over that. Cancellous bone, I typically use a gel foam with thrombin and a flowable to rub, and I rub the flowable into the cancellous bleeding. Around delicate structures, I don't typically like to go to electrocautery there. I typically use my flowable and my gel foam with thrombin. Inaccessible locations. If we can't successfully get to a spot surgically, that's a great example for a flowable. A needle hole bleeding, right? Putting a Surgicel or a gel foam over the needle hole bleeding, that can help the clotting cascade right over that needle hole. Now, here are the FDA-approved indications for topical hemostatic agents. I'm going to step through these quickly for each category, starting with the mechanical topical hemostats, okay? So the mechanical ones, that's the gelatins, that's the collagens, that's the polysaccharide spheres. What are they used for? You can see these check marks over here. They're used as an adjunct hemostatic device in surgical procedures. They're used when you can't control vessel bleeding by other conventional procedures, right? You can't get pressure. You can't do ligature. You can't reach the vessel that's bleeding. But now we're going to see in specific categories that some are used and some are not used, okay? So gel foam, you can use that for cancellous bone bleeding. Gel foam and Surgifoam, you can use it with or without thrombin. Like I talked about, I typically use it with thrombin, right? It's an additional pathway for the clotting cascade to work. Arista is not used for neurologic surgical procedures. That's potentially changing, and it's being studied right now, but right now it's not used for neurologic surgery. And ultimately, Arista and Surgifoam, it's not used for eye surgery as well. Gel foam and Surgifoam, you have to saturate it with sterile sodium chloride as well. Not so much important for when we're thinking about when is the right time to use it, just something to know about when we're thinking about using it. Here we have the active topical thrombins. And once again, this is used as an aid to hemostasis when there is oozing or bleeding from capillaries and small vessels. And you can't control it by other methods, the suture, ligature, and cautery. Okay, so this comes into the vessel is a hard to reach place. A perfect example of this is a epidural vessel, right? Hard to reach places, could be underneath the lamina, could be right near a nerve root, and I can't get a suture. I can't get cautery around it, and thrombin has a place for this. It's typically used for me in conjunction with a gelatin sponge. I don't typically use thrombin alone. I use it with a gel foam soaked thrombin. And here we have the flowables. And there's going to be one of the three specifically that's important for cancellous bone bleeding, which I see all the time. So first, let's go through all of them. They're all used. FlowSeal, SurgiFlow, GelFlow MT are used as an adjunct to hemostasis. It's the standard FDA approval, right? An adjunct to hemostasis. It's not the primary control of bleeding. It's an adjunct to help bleeding when other methods are not working. And it involves procedures involving cancellous bone bleeding. Well, FlowSeal and SurgiFlow are not for or approved for cancellous bone bleeding, but GelFlow NT is. So I don't typically use this, but this is something that's important to me. And I use a combination of other products to get my cancellous bone bleeding. I use a flowable with my gel foam soaked thrombin, but with GelFlow NT, we could potentially avoid that additional step. And that comes back to opportunity cost, right? These products cost money. If I can use one product instead of two, that's potentially beneficial. And here we have the fibrin sealants, VistaSeal and TisSeal. The one I have experience with is TisSeal, and it's used for sealing. It's also used for hemostasis, once again, as an adjunct for when other methods are impractical. Now, we want to think about how long these take to absorb as well. It's critical to understand that. Okay, so there are some downsides with the use of these products as well. And one of them is that they can stick around for a while. The longer it sticks around, you have the potential for infection or the potential to impact your post-operative imaging if you have to get it. So we think about Surgicel. Surgicel will absorb in about 1 to 2 weeks. When it absorbs, it can actually lead to drainage, which appears a little bit black. You have to understand that it's not necessarily an infection. It could be, it's just the Surgicel absorbing and the body getting rid of it. Collagen. I don't typically use collagen, but you can use a sponge or a powder, but that takes a long time to absorb, 8 to 12 weeks. And we're going to get to another slide very shortly, indicating that could be a problem. And I'm going to talk about that. Arista, actually it absorbs very quickly, 48 hours. Doesn't have a lot of side effects. Okay, so it doesn't create infection, granulomas, things along those lines. Gelatin matrix. This is gel foam. It takes about 4 to 6 weeks to absorb. Thrombin is immediate. Thrombin with the gelatin granules takes about 4 to 6 weeks, right along in lines with the gelatin matrix. And the fibrin sealants also absorb relatively quickly. I do want to go into the negatives. I didn't talk about bone wax before, but we're going to get into bone wax. We're going to talk about the fibrin sealants. We're going to talk about FlowSeal, gel foam, cellulose, and a few of the others about what adverse reactions do they have. Now, ultimately, safe ones, TisSeal appears relatively safe. Tranexamic acid appears relatively safe, but there's downsides to the potential use of other products, okay? Bone wax. So I didn't talk about bone wax before, but it's important because it comes into play for me for cancellous bone bleeding. It's a mechanical, right? We took bone wax, we put it inside the bone, and we actually use a device to place it into the cancellous channels. So we're basically preventing bleeding from coming out of those channels. It can create inflammation. It can also create an allergic reaction. People can react to this, and it creates pain. It creates wound complications. Not common, but it can happen. And in bony fusions, when we're doing spinal fusions like I do, bone wax can inhibit that. So I don't typically like to use it in situations where I'm doing a fusion. There's an alternative available called Ostine that absorbs quickly, doesn't inhibit fusion, and less inflammatory reaction. Gelatin-based products. They get their hemostatic effect through the mechanical swelling, tamponade, and provides a matrix for clot formation. But they can swell. If it swells in the spinal canal, it can contribute to spinal canal stenosis, and it's even led to paralysis or neurologic deterioration called Aquinas syndrome in some settings. It's very rare, but you have to use it in the right setting. Cellulose. Now, there's some favorable properties about this. This is bactericidal, less chance of infection, favorable biocompatibility, but this can also swell and cause nerve compression. This is important when we're talking about neurologic surgery. We don't want to put too much of this stuff in, because if we put too much and it swells, it can cause nerve compression. Now, excess cellulose can also cause granulation formation, basically create a granuloma. It very much looks like an infection, but it's not. Okay, so that's going to be important if you use too much of the Surgicel, for instance. So microfibrillar collagen. This adheres well to blood vessels. It promotes platelet aggregation. But I will tell you, there's an idiopathic inflammatory reaction that's possible with this. And if I get a postoperative MRI, I want to know what I'm looking at. I don't want to see a radiographic appearance of a tumor or an abscess. That could just be the collagen sponge that I used. All right, so that's going to be important for when we're making determinations of what we should do, for what products we should use. Polysaccharide hemostats, this is the Arista. This is actually completely absorbable and limited potential for granuloma and infection. I think this has a very favorable property. It's just I don't have it available in my hospital. Polyethylene glycol. It's used as a sealant for dural repair, but can also be used for hemostasis. The most significant worry I have about this is it can swell to 400% of its original volume as you put it in, and that can cause neurologic compression. So there are low swell formulas available, but it's important because I still have the high swell formula on the product. The exact product I use is called Duraseal Exact, right? That's the low swell formula. So when you're using polyethylene glycol, you have to make sure you get the right product and not just using any product off the shelf. That's where communication with the team comes into play. Now, I do want to talk about the coagulation cascade and where we're mostly focusing on. So the topical mechanical agents, what they're going to be doing is providing a matrix for clotting. They're going to also activate platelets. Active agents are going to be working on thrombin, fibrin, and helping stabilize the fibrin clot. So there's different areas we're going to target on the clotting cascade, but what's important is I want you to just know about this. I don't want to go into full detail about it, but there's multiple thought processes going to how we're going to target the clotting cascade. And so we're targeting it in multiple areas, as you can see here. I do want to go into the types of bleeding. All right, so we have subcutaneous bleeding. Okay, now typically that's approach related. Electrocautery is great for this. Retraction, mechanical compression are the best agents. And I would say a mechanical active combination for inactive surgery sites. What do I mean by this? That means I've already dissected that area. I'm no longer there. There's a little bit of muscular bleeding or subcutaneous bleeding that I can't control with electrocautery. I'll typically place a flowable or a Surgicel with a gel foam soaked thrombin in that region so I can prevent bleeding. Bony bleeding. Typically, I use bone wax if there's no bony healing or fusion required. I use cellulose or collagen-based products. For me, like I said, I use cellulose-based products more so than collagen. I'll use flowable. However, there's only one FDA approved for cancellous bleeding. That's Gel Flow NT. Epidural bleeding. I typically use bipolar cautery, but I will use a flowable with thrombin if unable to identify that vein or if it's dangerous to go after that vein. Muscular bleeding. I think a hemostatic powder is a great option for that. Arista is one of those. Compression, electric cautery are also important as well. Large blood vessels. Typically, hemostatic agents are used as an adjunct, but not as the primary agent for a large blood vessel bleeding. This comes into play with our vascular approaches, our ALIF approaches, and our vascular surgeons will place Surgicel or a gel foam soaked thrombin around a major vessel bleed if it does occur. Well, that's all about the time. That's about all the time we have today for this CMEO snack. Before we sign off, I'd like to thank my colleague, Mike Capito, for joining me today. And thanks to you, our audience, for participating. Now, here are 2 SMART goals associated with today's program. SMART goals are take-home actions that stand for specific, measurable, achievable, realistic, and timely. Ultimately, I want to go into both of these. Evaluate topical hemostatic agents for procedures increasingly performed in outpatient departments and ambulatory surgery centers, and selecting topical hemostatic agents based on the type of surgery, amount, location of bleeding, and surgeon preference. I think those are all important things. And thank you for joining us again today. Don't miss snacks 2 and 3 in the series, where we'll demonstrate how to prepare topical agents for use and discuss tips and pearls for using them in actual procedures. Thank you and be well.